I know most of you folks here today. So I'm Rebecca Cunningham, Director of the Center, and we're very excited today for our lunchtime seminar, which I'm going to remind you that we are webcasting as well, so we'll have questions. And Bethany, are you monitoring the questions as they come in that way as well? And we'll have available on our website later. If you are not very familiar with that,
could you go closer to the mic?
If you're not familiar with the center, we have some center brochures for you as well, which will give you some more information. The other only main events I want to bring to people's attention, we are having, in addition to our other upcoming seminars, which are on our website, we have 2 large summits that we're proposing for this fall that are in planning. One is on concussion and one is on prescription drug overdose. So if you have colleagues or yourself are interested in those topics, look for our announcements that will come across our website on those topics. And we're happy to answer any questions on those. And then I just wanted to take the opportunity to introduce Dr. Prosser, who is an associate professor in pediatrics and associate director of the CHEAR Child Health and Evaluation Research Unit. And she also holds an adjunct faculty position, I see, at the Harvard Health, who has focused on comparative effectiveness and cost effectiveness in child health interventions and methods of decision science and economics. And we are so excited to have her today. I will let her further introduce her.
Great. Thank you very much. I'm really excited to be here today. We'll be talking about economic evaluation, child health policy. Rebecca and I have been working together I've joined a number of grant applications, and none of those have come through yet, but there's a need for research in this area. So just as a preview, I'll be focusing primarily today on examples of economic evaluation, child health policy, not specifically in injury, but on the prevention side, and thinking about this as a model for how we can do economic evaluation, examples of how it can be used to demonstrate the value of different interventions for use in policy analysis. And I'm very happy to take questions along the way. I hope this will be a discussion and not just a one-way transfer here. And so please, and I just like to start by getting a sense of who, if anyone, has been involved with economic evaluation or cost effectiveness studies in the past. Great. Or has taken coursework or has an interest in the topic. Terrific. Okay, great. Good. So I'm going to start with just a brief introduction and some of the terminology that we'll be using and examples of how cost effectiveness evidence has been used in vaccine policy. And then if there's time at the end, I'd like to talk a little bit about some new research that we're working on that focuses on measuring and incorporating family spillover effects in economic evaluation. So especially when we're thinking about child health, there are often impacts on health-related quality of life for caregivers and other family members in an area in which there's not been a lot of attention in the economic evaluation research world, and to be able to measure those effects and incorporate them as they represent a substantial burden when we're thinking about what's the burden of illness for child health, for child illness. So I'm going to start with some definitions and some common misconceptions. So the first is that when we're being cost effective, we do not mean that it's cost saving, that there are many things that we purchase that we would never expect them to return. If we buy a car or a house, we don't expect that to save money, but what it's going to do is deliver transportation or provide shelter for us. Same thing for when we invest in health, that the expectation is not that it's cost saving, but that we're going to be purchasing some amount of health. So either we're going to be averting mortality or averting morbidity for that investment. And what we're interested in when we're thinking about cost effectiveness is how much value we're getting for that investment. And so cost effectiveness analysis specifically is a type of economic evaluation in which we're comparing the relative costs and the relative outcomes of 2 or more alternatives. And it can be used by decision makers to assist with resource allocation and policy decisions, especially when we're in the context of a budget. So say within, so it's used right now more often in countries that have national health systems, and they are really working within a strict health budget, which we don't typically have here. And we'll talk a little bit about the barriers to using cost-effectiveness analysis in the US. But within that, cost-effectiveness analysis can be helped to target which interventions are really providing the most value and directing investment towards those interventions. So this slide just lists the types of economic evaluation. We'll just go through this terminology quickly. So a cost analysis is where we're measuring costs, but we're not focusing on measuring the health consequences. And this is almost never the correct type of evaluation to use. So unless we can be absolutely certain that the health consequences are exactly the same for the two interventions, if we only look at the costs, then we're missing, half of, what we're trying to measure. One exception or one example where we would want to use it, if we use a vaccine example, is if we're looking at vaccination in different settings. So vaccination in a traditional physician office setting versus a mass vaccination setting. We know that the effectiveness of vaccination is exactly the same if it's delivered, in both of those locations, but the costs of the delivered vaccine will be very different. And there we'd be looking at cost analysis and interested in minimizing costs. But another example, if we were looking at two different types of vaccines, so thinking about influenza vaccine, if we're looking at inactivated vaccine versus live attenuated vaccine, where the effectiveness is different, that live attenuated vaccine for certain age groups has been demonstrated to be more effective than inactivated vaccine. It's actually the reverse in other age groups. And so if we looked only at costs, we could potentially be misallocating and misdirecting resources by targeting the wrong intervention. So cost effectiveness analysis is when we're measuring costs in monetary units. So here we'd be using dollars, and the measurement of health consequences in natural units. So again, going through a vaccine example, things like influenza events averted, hospitalizations averted, deaths averted. Cost utility analysis is a special form of cost effectiveness analysis in which the measurement of health outcomes is quality adjusted life years. The quality adjusted life year can be thought of essentially equivalent to a year in perfect health. And what quality adjusted life years allow us to do is basically to roll all of those outcomes into a single common metric. They allow us to compare across very different conditions, very different types of illnesses, using a single metric, quality adjusted life years, that incorporates both morbidity and mortality. And I'll give an example later on that demonstrates how that works for influenza illness. The last type of economic evaluation that's typically used for evaluating health is cost benefit analysis. There, the measurement of costs would be the same, but the measurement of consequences is in monetary units, typically willingness to pay. And willingness to pay is typically asking survey questions to the general population, ask people how much they'd be willing to pay to try to capture that value of averting either morbidity or mortality or a reduction in a risk. So typically those questions will be framed in terms of how much somebody would be willing to pay to reduce the risk of, say, an influenza-related death. Or it's been used quite often in transportation safety, so the risk of using a traffic fatality would be another example. So we're going to be talking today specifically about just cost effectiveness analysis, primarily cost utility analysis. One thing to note is that you'll often see these terms used interchangeably in the literature, that people will use cost effectiveness to refer to a cost per quality adjusted life year ratio. Okay. So that's it in terms of the introduction to the terms that we're going to be using. And now I'm just going to go through a couple of questions that often come up when we start talking about economic evaluation and the value of different interventions. So the first question is, are prevention programs always cost saving? Thoughts on that? Yes? No? No. Depends. So that's great. Everyone said no. So this slide shows the distribution of published cost effectiveness ratios from the Tufts Cost Effectiveness Registry. So starting left, so we can see that back to the earlier question, does cost effective mean cost saving? So here we see that in the distribution of, and these are published effectiveness ratios, do not necessarily imply that these are ones that are used widely or not. So this is just the universe of published studies. But within that, so the proportion that's cost saving are around 15%, both for prevention and treatment. Then we see a distribution of ratios, and we'll talk more about what these mean in terms of dollars per quality adjusted life year and what that threshold might be Over here on the other end, there's also some proportion of ratios in which the interventions are dominated. And that means that the intervention is both more costly, yet delivers fewer health benefits than the intervention it's being compared to. And question is, at first you might think, well, that area are category of interventions that we would never want to invest in. But what we see is included in some of those interventions include things like end-stage treatments for end-stage cancer. And what is happening there is that this is where when the conventional economic framework, we're thinking about a risk-neutral framework for population-level policy decisions. But at the individual level, that when people are making individual treatment decisions, that especially at that for certain patients, that they may no longer be risk-neutral. They may be risk-seeking. And so that if we're looking at a ratio that's done under risk-neutral framework, it may look very different if you're risk-seeking. So those may be some interventions. So from a population level, they wouldn't necessarily be a program that we would want to invest in, but from the individual perspective, there could be a difference there. And we'll talk about that a little bit more, that what the role of cost effectiveness analysis is for population level decisions compared with individual decisions. Okay, so we've done away with the second conception that prevention is cost saving. So we know that prevention programs are not necessarily cost saving, that they show the same distribution of cost effectiveness as treatment interventions. And one of the things here, this came up a lot during around the discussion around the original passage of the ACA legislation, that there was quite a bit of rhetoric around, well, we're going to invest in all these prevention programs, and then that's going to fund, everything else that we're investing in and the expansion of the program. And so that was very troubling to many of us, and it's very, very heartening to see that there's been very little of that more recently. But you will hear that very often, that there's this common, thinking that an ounce of prevention is worth a pound of cure, and in some cases that's true, but it really depends. So we have to do the evaluation to figure out when that holds and when it doesn't. Especially when we're thinking about screening programs. So one area that I do a lot of work in is around newborn screening, is that we're screening 4 million newborns every year across the country for a set of conditions. And so even though the incremental screening cost is very low, that it depends on how many children we're detecting with that condition, whether or not the screening program is cost saving, cost effective, or not. So another question that frequently comes up is, are pediatric interventions more likely to be cost effective than adult interventions? So any thoughts? You think yes? No? Depends. So this is another case where we're not so sure, that it looks like there may be a trend that children's health interventions might be on average slightly more cost-effective interventions, but overall we see a very similar distribution. That again, about 50% of pediatric versus adult are cost-saving. The median cost-effectiveness ratio is lower for pediatric interventions than adult interventions, but not statistically significant. And again, we see this tail end of about 10 or 11% of dominated interventions. And so it really depends on which ones we're looking at. So if we look at vaccines that have been recommended by the Advisory Committee on Immunization Practices over the last 10 years or so, we see a very wide range of cost effectiveness ratios, from cost saving all the way to more than $200,000 per quality adjusted life year gained. Now, some of the older vaccines, so vaccines that were initially recommended back in the 60s and 70s, those vaccines tended to be more likely to prevent deaths than morbidity, and overall were more likely to be cost saving. But the newer vaccines that have been introduced over the past 10 years or so many of them focus on averting morbidity and have a lower effect on mortality. And so there we see that the balance has changed, and there really has been very wide variation in the cost effectiveness of recent vaccines that have been considered by the ACA. And then this slide shows just a convenient sample of selected cost-effective studies on injury prevention. We're talking before the break about how there has been very little research in around firearm injuries or preventions over the last many years, and that's reflected when we look at this registry of cost-effectiveness analyses. So I searched for looking at injury prevention, traffic safety, firearm violence, and on the whole, there are really only about 30 or 40 cost-effectiveness analyses included in this database. And whereas if you search on vaccines, there would be hundreds and hundreds of analyses, and there are more than 7,000 ratios in this database altogether. So an enormous opportunity for doing research in this area and really contributing to the field and trying to understand what the view of different programs together. But again, what we see here, just in this convenient sample, is a range. So cost saving all the way up to $100,000 for quality adjusted life year. And so just going back to this slide again, so then the question comes up, well, what is cost effective? At what level do we decide, well, it's worth investing in or not? Is it, $100,000 per quality adjusted life year, $250,000, more or less? So here in the United States, there's no one threshold that's used for determining cost effectiveness. So other countries do have specific thresholds that they use for identifying whether or not a health intervention is cost effective, and it will be supported by their National Health Service. So for example, in the UK, it's £30,000 per quality adjusted life year gained. So approximately $50,000 or so per quality. Although there are exceptions to that based on whether it is for an orphan disease or for a patient population where there aren't any other treatments available. So for example, when multiple sclerosis treatments, interferon betas, first were evaluated by UK NHS about 10 years ago, the cost per quality was much higher than £30,000, but there was an outcry from patient advocates because this was a group of patients for which there had really been treatments available to slow or prevent progression of disease. And so they actually used a different threshold for that group of drugs, a little bit higher than £30,000 per quality. So coming back to the States, there's increasing evidence that there is no one threshold that could or should be used, that it varies, societal preferences vary based on what the type of health effect is being prevented. Are we preventing a death, or are we preventing a lot of minor illnesses? So we could think about bundling those into qualities that, so we could have a stream of quality adjusted life years that was due to a vaccine that averted one death in a child, or due to preventing, thousands and thousands of illnesses. And those would both be equal to one quality, but as a society, we may have very different preferences about which one we want to invest in. And so tend to have more of a preference towards preventing deaths than preventing minor illnesses. And that there also seems to be some differences in terms of that preferences towards priority towards children and adults, although there is some preference towards very elderly adults as well. The least preferred group, would be kind of working age adults, and as well as the types of interventions. So what's the timing of the intervention? So is it a prevention program where you were preventing statistical life or saving a statistical life, or is it an intervention where we're saving an identified life? And there's clear evidence that there are preferences that people prefer to save identified lives as opposed to statistical lives. So coming back to thinking about prevention programs, that suggests that if there is a single threshold, that it's probably a little bit lower for prevention programs than if we're comparing to treatment programs, although again, it's going to vary on the population, the type of intervention, the type of health effects. But in general, that if we look at policy decisions and use cost-effectiveness analysis, the implied threshold is somewhere between around $100 to maybe $250,000 per quality adjusted life year. Kind of $100 to $150,000 per quality is typically used as a general range, although that will vary depending on the specific context. And kind of thinking, going forward to how cost effectiveness is typically used in policy decisions, it's as one input to the decision-making process. So, we're not in a setting, where cost effectiveness is a strict criterion that needs to be met, but really we are in a situation where it's taken into account as one category of evidence compared to all the other categories that are being considered at the same time. Okay. So I'm going to talk a little bit about how it's been used here in the U.S. Any comments or questions at this point? Okay, great. All right, so so here in the U.S., we've seen an increasing pace in the number of effectiveness publications over the last 25 years. So thousands and thousands of cost-effectiveness studies published. We don't know if these have actually been used in policy decisions here in the United States. So there are a lot of challenges to the use of cost effectiveness in the United States. Primarily, it's due to the fragmented structure of our healthcare system, that there is no one decision maker that's allocating a healthcare budget. There are specific, there are some organizations that we would think of as users of cost effectiveness analysis, such as CMS, but there have been historical barriers to incorporating any type of economic evaluation into those coverage decisions. And in fact, it's been legislated for CMS that they are not allowed to use cost or cost effectiveness to determine coverage for any types of interventions. So we also hear a lot of political resistance, and really there is also the effect of cultural attitudes here in the U.S. that there really is kind of an expectation that people expect to have access to everything that's available, and we don't have this culture of kind of limit setting or resource limitations here in the United States, and that has come through in the legislation as well. So I just want to talk a little bit about what happened in the ACA. The development of the ACA legislation, those of us that do cost effectiveness analysis were very excited to hear that there was an opportunity to incorporate evaluation. So along with the expansion of coverage, that coupled with that, the original discussion of the legislation included a component to limit costs through the use of economic evaluation. During the deliberations is that provision 6301 was inserted into the legislation and stated very specifically, and so this is specific to PCORI, which was created to fund comparative effectiveness analysis, on behalf of the ACA. So it's funded through the ACA legislation that PCORI gets each year, $1 for all publicly covered individuals and $2 for every private individual. So works out to more than $500 million of funding per year for PCORI, and their charge is to do comparative effectiveness analysis to guide investments in health interventions. So this provision says PCORI shall not develop or employ dollars per quality adjusted life year, or a similar measure that discounts the value of life because of an individual's disability. So this blanket statement prevents anything similar to equality, like no DALYs, no healthy year equivalents, anything that adjusts life due to the quality of life is banned by PCORI. So it can't be used as a threshold to establish what type of healthcare is cost-effective or recommended. So this has put a real damper in terms of, being able to, we were very concerned, like we all went into a deep depression when this, when this legislation first came out. But it's interesting to see that this has not really spread too much beyond PCORI, that there is still funding for cost effectiveness and other types of economic evaluation from NIH and other federal agencies, as well as from CDC, and that actually increasing interest in the use of cost effectiveness analysis in terms of using it in policy guidelines, as well as developing guidelines for clinical guidelines. Yeah.
So it's very interesting. And we're certainly seeing on the NIH side, we're starting to be thinking this kind of thing as an aim in some of our education. Yeah. So I may have missed, but so what exactly drove this? So what was the advocacy for what? How did this exactly come about so that we can miss that landmine?
So that's a really good question. So I know this is being recorded, so my disclaimer is that this is all a discussion, that I haven't seen anything printed about where this came from. But so what? No. But I think it is interesting though, because that it seems as though this was inserted by a coalition between the pharmaceutical industry and right to life groups, that they together they lobbied to have this inserted. So that's what I've heard.
I'm just trying to understand.
Not evidence based.
It's not obvious to me what groups would not want to understand the process.
So primarily the pharmaceutical industry has a large stake in not having any kind of cost effectiveness analysis done. So along with what with no strict health budget here, we don't have any any specific price setting for pharmaceuticals as they do in most other countries. So they have.
So maybe less for injury prevention. Maybe we can be less concerned
I think
around
that's
for injury
true.
prevention.
Right.
Because we're seeing injury prevention, we're seeing this is the stuff.
Right. Yeah, that's a really good point. Yeah. So I'm happy to say that we really haven't seen as much of a damper as we would have thought, and that one of the areas, newborn screening, that I do a lot of work in, that the Federal Advisory Committee that makes decisions about what conditions to put onto the recommended uniform screening panel. Right now, we're having discussions about how we can explicitly incorporate both the consideration of cost and cost effectiveness into their formal decision-making framework. So there are areas where it's being used here in the U.S. And what I'd like to talk about for a few minutes is how it's used for U.S. vaccine policy, because this is a nice model of how it can be used to inform policy. So the ACIP, the Advisory Committee for Immunization Practices, sets national recommendations for vaccination for a variety of different conditions, and goes through a formal evidence review process. It's a public process, so then they have public comment. So typically the ACIP meets 3 times a year. So when there's a new vaccine that's coming to market, they put this process into place many years beforehand. Because the one nice thing about vaccines is that they know, it's going into phase 3 trials, and so they can put this process into place. And so they start doing evidence review around 5 different categories. So disease burden, vaccine safety, vaccine effectiveness, economics, and impact on providers. And economics have been part of the deliberations of the ACIP since its inception in the 1980s. So from the very beginning, they considered this to be an important part of the decision-making process. But it's important to note that it's not the single criterion, and it's not the driving criterion in these deliberations, by any means. And that the importance can vary from vaccine to vaccine, depending on what the other levels of evidence are. So I'm going to go through a couple of examples of how it's been used in influenza vaccine, and then just talk a little bit about family spillover effects. So We've done a series of studies looking at the cost effectiveness of both seasonal and H1N1 influenza vaccine for different age and risk groups, funded by CDC and in collaboration with CDC over the last 15 years. So this slide just shows how current recommendations have been expanded for annual influenza vaccination over the last 10 years. So starting in the early 2000s, there were a couple of studies that came out showing that hospitalization rates for very young children were just as high as hospitalization rates for the elderly, and influenza vaccine, routine annual influenza vaccine had been recommended for many years for anybody the age of 50, but was not recommended routinely for kids. So the conversation was started, should children be included in this recommendation, at what ages and what risk groups? And so we conducted a study looking at how the cost effectiveness of influenza vaccination differed by both age and risk groups for children, looking at both high and low risk and dividing into different ages based on how the risk for both hospitalization and mortality changed. Over the last 10 years, CDC has incrementally increased the number of covered groups, resulting in a universal flu vaccine recommendation in 2010-2011, right around the time of H1N1. So just to include this disclaimer that this work has been conducted jointly with CDC investigators, but reflects our opinions, not necessarily the views of CDC. Okay, so going into the methods of this analysis. So this slide shows a simplified schematic for the simulation model. So most of the cost effectiveness analyses that we conduct, we use simulation modeling to project both costs and health outcomes. You'll also see trial-based cost effectiveness analyses in the literature, but typically there is also some modeling that is included in those studies as well, because we often need to model beyond the time frame of the trial, or we need to model different subgroups than are included in the model, or sometimes we'll be modeling different costs because the costs of the intervention in the model in the trial don't reflect what would happen in a real world setting. So there's often modeling involved. So this is a simulation model in which we run two cohorts, identical cohorts through the simulation model. One cohort gets vaccinated, one does not. If they're not vaccinated, they face a probability of getting influenza, having a physician visit along with their influenza, being hospitalized due to influenza. If they're hospitalized, they can die or survive. It's a simplified model, so for example, some of the simplifications that we have to make are that people can only die after they've been hospitalized, whereas we do know that there is a small proportion of people that actually die from influenza before they get to the hospital, so they're ignored. As they travel through the model, they collect costs, so the costs associated with each of these health events. They also collect quality of life values, so QALYs that are associated with each of those health states. So for example, they would lose a small piece of a QALY for having influenza. If they die, they'll lose all of the QALYs that would have been projected for the rest of their lives. For those that are vaccinated, they experience a side effect due to vaccination. Again, those are all also associated with costs and potential quality losses associated with the side effects. They face the same set of influenza outcomes, but at a reduced probability due to the effectiveness of vaccination. Not completely averted because influenza vaccine is not 100% effective. So this slide shows our the primary endpoints for the analysis and the cost effectiveness ratio. So once we've run the model, it's just the sum of the difference between the costs of vaccination and the cost of no vaccination divided by the difference in QALYs between the two arms in the simulation model. And so this slide shows our cost effectiveness ratios for different events. And it's just an example of how if we had only the cost effectiveness ratios for influenza-specific events, it would be very hard to compare across different conditions. But once we've translated all of these different endpoints into quality what we found is that the cost effectiveness range varied really substantially by age and risk group. So for high-risk kids, from cost saving up to about $25,000 per quality adjusted life year, but for non-high-risk kids, from $20,000 per quality all the way up to under $36,000 per life year. And so the original expansions of the influenza vaccination recommendations included all of the high-risk age groups. And then over the next few years, they expanded to healthy, younger age kids. But there was a question about this last group of school age and healthy adolescents, given the difference in cost effectiveness. And those age groups were on due to an argument that there was really low coverage among the high-risk groups. And the objective was to simplify the recommendation for providers and for parents in order to improve coverage among the high-risk groups. And that was the rationale. So it was not based on vaccination, but on other considerations. So this slide just shows some of the sensitivity analyses. One of the important results from cost-effectiveness analysis is that we can understand which parameters are driving the results and which are not. So if we look at that previous slide, there were confidence intervals. So those are simulated confidence intervals because each of the inputs into the model is represented by a distribution, not by a single parameter, because we have uncertainty around all the parameters that are going into the model. And so it's important for us to know kind of where that uncertainty is coming from. And here, it's really driven by the illness rate, but we can also see that vaccine effectiveness is an important driver in total vaccination cost. So one of the other implications from this analysis was that there was an increased emphasis on targeting vaccine towards mass vaccination settings, lower cost settings, where we'd be getting better value for vaccination.
I have a question too.
Yeah.
You have reduced transmission there.
Yeah.
And I wonder, I mean, that's got to play into the cost savings, right? Because if the
Yeah.
high-risk group that's more likely to die or have, is more likely to be infected if everybody else isn't getting vaccinated, right?
Right.
But it's complicated.
So, right. And so that's a really good question because ours is actually not an infectious disease dynamic model. So we only modeled very limited transmission effects to the immediate family. And we did that intentionally because the objective was to be able to look first at the benefits to the individual that was getting vaccinated and to look secondarily at the benefits to the population, under the assumption that this would be driving towards a universal recommendation. Because if you have a universal recommendation, then there will still be some transmission effects, but they'll be fewer than if you're, because one of the big things that came up during the H1N1 and during other years in which there's been a shortage of vaccines, which groups then do you prioritize? Do you prioritize the kids that may have fewer direct benefits but are more likely to prevent transmission or to reduce the further effects of illness? So, question. So I want to move to post-2009 seasonal influenza vaccination because after the introduction of H1N1 in the late 2000s, the epidemiology of influenza illness changed since now H1N1 is one of the circulating strains and has a very different effect on different age groups. And so once we've incorporated that into the model, we can see that there is the overall cost effectiveness dropped dramatically. So now we're looking at kids where even in those adolescent groups that had really high ratios before, it's now below $10,000 per quality adjusted life year and much lower in adults as well. But one of the other pieces of recent evidence that's come out is that influenza vaccine may be much less effective in the elderly than we originally thought. And one thing that we can do using modeling is to evaluate kind of how low can you go. So we used in this analysis a base case of 35% effectiveness for vaccine in the elderly, but then there are studies that suggested that it may be even lower than that. So the question was, if it's cost saving at 35% effectiveness, what happens, if it's only 10%, and is it still worth vaccinating at that point? So we did an analysis looking at how the cost effectiveness changed according both to different costs of vaccination, ranging from $25 up to $55 per vaccination, and the average right now it's about $25 for in the elderly. So you're looking at much higher costs of vaccination and much lower effectiveness. So even if we're down at 10% or even at 5%, that it still looks, but if we're looking at the threshold around $100 to $150,000 for QALY, it still looks worthwhile to vaccinate in the elderly because their rates of mortality are so high. So this is just what we had talked about in terms of, so the cost effectiveness evidence, so just to recap kind of how it was used in the policy discussions. So it used to understand how the investment varied by both age and risk status, and that was reflected in how the recommendations were expanded over time, and also to highlight the difference in cost effectiveness by vaccine setting, and to really put an emphasis. And you'll see, compared to 10 years ago, you can get a flu vaccine in so many different places than you could then, and now we're looking at school-located settings as well. And that the cost-effectiveness evidence post-2009 H1N1 does support a universal recommendation across all age and risk groups. Just want to skip to one last example. So we did an analysis of the H1N1 vaccination program. And what happened, you remember during the H1N1 epidemic that there was a first wave in April, and there was production that was started for H1N1 specific vaccine, and the government had to make a decision in the summer whether or not and how many doses to purchase. And so the decision was made, before the next wave hit, to purchase, a certain number of doses. It was over 200,000 doses. And what happened is that the next wave hit a little bit earlier than they had anticipated, and there were delays in vaccine delivery. And so the question was, is it still worth it to vaccinate once we're well into the epidemic? This original analysis looks at the cost effectiveness based just on assuming that people are fully vaccinated before the influenza virus starts circulating. So we wanted to ask the question, if they're vaccinated 3 weeks or 5 weeks or 8 weeks into the epidemic, is it still worthwhile? Because there will be likely fewer health benefits accrued. So looking at this analysis, so this gray in the background represents a typical 8-week influenza epidemic that peaks in the middle. And so what we're able to do is to show that if vaccine is delayed, even as much as by 8 weeks into the epidemic, that it still looks cost effective for all of the age and risk groups, except for this group. Those are 65 and over, and they weren't recommended for vaccination anyway. So as long as they were vaccinated before the peak of the epidemic, that it was still worthwhile from an economic perspective. So I'm going to pause here and open it up for questions. If we have time, we can talk about family spillover. But if not, I'm happy to talk about that anytime. But just a quick summary. So the role of cost-effectiveness evidence is provided key insights for development. It's rarely used for global coverage decisions, but where it's been used much more often is for identifying target populations. So which risk subgroups or age groups are we likely to get the best value from our investment? And it's increasingly being used to support guideline development. So we've seen it used for guidelines for cholesterol drugs and for other national guidelines. So there's been an increasing use in ACIP. It's been used for many, many years by CDC in all of their branches. They have health economists embedded in all their branches, and they use economic evaluation on a continual basis. It's being used more often in newborn screening. We're seeing more promotion of cost effectiveness, other economic evaluation methods in the Choosing Wisely campaign, which is being spearheaded by a number of medical professional organizations in their guideline development. And I'm also happy to hear that it's being requested by the NIH as well as part of a trial application. So let me pause there and open it up for questions or comments.
I'll start. So in thinking about, we found, I know we worked together a few years ago to look at the cost per event averted of our CPT evaluation, which we found that having that data after that is incredibly helpful for everything about programs and to advocate for it. But in thinking about it, one of the knowing less about this type of field and thinking for these investigators as you're starting programs up and you're maybe doing preliminary research around your program, you don't yet know if it's effective, so therefore it's hard to imagine how you would factor in what your costs should be later on to figure that out. What should we be thinking about as we plan trials to talk to junior investigators about baking in, because you don't know whether it's going to be effective or not later, but once it is, it's really nice to collect a few things along the way.
Right.
How can we help think about getting that set up so that if we are so lucky to find out that our programs work, we then can make some discussion or analysis later on about how much they work in a value-based way.
That's a really good point. And couple of comments. So one is to include an evaluation of the costs. So even if it turns out not to be cost effective, that's an important analysis. And so although, what I said in the beginning is that, if you don't have equivalence on the health effectiveness side, then the cost analysis is not the right way to go. There, that would be a different type of cost analysis, more of a descriptive analysis describing the cost of the program. And as he said, that can be used in many ways in terms of defining and creating new programs. So I think the key is, if you're developing a new program, to do primary data collection of the costs as part of the trial. And you can include that in the grant as, just as a cost. It's, very, very low cost to collect those costs when you're doing it during the trial. Exactly. But to go back and try to retrospectively estimate those is much more difficult. So, and reviewers are very, view that very favorably if you're including that piece. And then if there's room, you can write in a cost effectiveness component. But I've certainly been a part of trials where it's turned out not to be effective, but we have published the descriptive cost piece on its own, and that's certainly been a valuable contribution to literature. Yeah. And then the cost effectiveness piece, if it does turn out to be effective, can be included as a separate application, or can be done, separately with separate funding, even from another funder.
Yeah. The other part that I found very helpful from our work together was thinking about, because we don't modeling the end cost, as you mentioned from your first slides, of how violence, for example, is impacting their quality of life. We don't have all those metrics very well defined. And so thinking of it in terms of the cost of our event averted, which was a violent event, or work with child maltreatment, cost of event averted, which might be something that's more accessible to our research, cost of crash averted, for example.
Right.
Crash, I think the costs are
right.
So I don't know if you have any other comments on that.
So I just want to say, so I think, that's an important area, and there are health utility or quality adjustments that you can find in the literature for a number of different types of injuries that are available. And we have been working on a child quality of life instrument, but it has been really challenging because we're including things that are not typically included, as part of the measurement of health-related quality of life. You're thinking about, how do we incorporate into current quality of life the effect of risky behaviors, which may be, a consequence of child maltreatment. So we're not quite ready to publish those findings yet, but we will be pretty soon. But I think that's an important area.
So with regard to violence, it seems like the qualities that generally used in terms of health, you're perfect health. But in the case of violence, in addition to, say, injury, there's also incarceration. There's also, there are a lot of other kind of externalities, right, that have costs. costs
Yeah.
too. So if I spend a year in jail, what does that do to my qualities?
Yeah.
So do you understand what I mean?
Yeah.
There's a lot
And
of
so that's
complexity.
Yeah, so I think there's a lot of opportunity there. So, I mean, the standard cost effectiveness framework has really been applied primarily to health interventions. And economic evaluations for non-health interventions have typically used cost-benefit analysis, which then try to translate those outcomes into a dollar value. But I think there is a lot of crossover between the two, especially when we're thinking about public health programs. And there are ways of valuing those for looking at the cost effectiveness of autism treatments. So there we would include special education costs, which are not, they're not typically considered health costs, but those are important costs and also something that will be averted with an effective treatment. Yeah. So we would want to include those. Yeah.
Is it necessary when you're developing the cost effectiveness study or publication? Do you have to necessarily go to clinical trial, or can you use current literature developing the probabilities and costs associated with each of those branches in the tree?
That's typically how we do it. So I think it's rare to have trial-based cost-effectiveness analysis unless it's a pharmaceutical drug. So that's very typical for pharmaceuticals to piggyback that onto a trial, but not as typical for other types of interventions. So most of our studies are simulation studies where all of the inputs to the model come from a wide range of sources. We do have some primary data collection, retrospective data analyses. We'll conduct literature reviews to extract some parameters from there. And then where we really don't have any data, we'll use expert opinion. And that's where we'll use sensitivity analysis to really vary that parameter input so that we can understand the effect of that uncertainty. And then, because if you're using a simulation model, you really have more than just the cost effectiveness evidence. You also have all this information on both projected costs and all the different projected health outcomes. And that piece alone has also been very important to decision makers in terms of understanding what the impact is on different types of health. And you can really think of that piece of it as a form of evidence synthesis. And so we are using the literature for most of it.
And how about the quality?
Same thing. So we have done a mix. So sometimes there are good health utilities that we can use to generate qualities that are available in the literature. For child health, there's much less. So we'll typically collect our own primary data for those. Yeah. Other questions?
Thank you so much.
Great.